They say that around 60% of concussions can impact vision, but what exactly does that mean? Over the course of the next hour, what we'd like to do is to let you in on a lecture where we discuss post-concussion syndrome and the visual impacts that it can create. What we're going to namely be talking about is our Canadian Journal of Optometry study on post-concussion syndrome. And we're going to be presenting it using language that should communicate with a wide audience, be they optometrists, ophthalmologists, allied professionals, or insurance adjusters. Essentially anyone who even has a passing interest in vision should find value in viewing. What we found within our post-concussion cohort was that at initial presentation, these individuals were presenting at around 40% of age-normalized visual function. So we're going to take you through exactly what that means, the tests that we use, and how the results of these tests could impact function. After use of therapeutic glasses, which we'll describe within the talk, and generally between 15 to 20 sessions of in-office vision therapy, what we found was that the same cohort was now operating at about 95% of age-normalized function and had seen a 50% reduction in visually derived symptoms. You can imagine that with this improved visual performance, they would see gains in their ability to return to school, return to sport, or return to work. So we really do appreciate you tuning in, and of course if there's any questions that this lecture doesn't address, please feel free to reach out via our website, okanaganvisiontherapy.ca. Thanks so much for tuning in. Basically what we're hoping to talk about here are what are the statistical trends that we can expect to see within post-concussion syndrome, and what sort of changes can we expect to see following vision therapy or use of therapeutic glasses or training glasses, and talk a little bit more about what that is. So when they talk about concussions, they often talk about it being the hidden disability. So you can see someone, they look fine, they look healthy, but they're really hurting and they're really struggling. And I would argue that the functional visual impact, as we said with the title here, is almost an invisible deficit. And the beautiful thing about what we can do as optometrists is we have the ability to measure what would be considered invisible and communicate with other practitioners on a very objective, scientific basis regarding what it is that we're seeing. I spend a lot of time, lecturing with non-optometric professionals, so physiotherapists and occupational therapists and psychologists and lawyers and just anyone who has even kind of a passing interest in vision training. And so it's really nice to kind of come back and speak with optometrists and kind of speak my native language. We can kind of speak a bit more optometric-ese and kind of how we can communicate that to other professionals and pass that along. So in terms of the basis for this presentation, over the last number of years, I had started to notice there's patterns in terms of how post-concussion syndrome presents. So at the clinic, I think I mentioned we probably see somewhere between 400 and 500 concussions a year. And what I was noticing was there's these very common trends that you start to see in the optometric data when someone has post-concussion syndrome. And as a result of those trends, you can outline a treatment plan or you can get them in the direction of somewhere to get help. So following concussions, one of the interesting things, we know that in the adult population, about 50% of concussions are going to have some type of visual impact. And in the adolescent population, it is closer to 70%. So we know how much of the brain is used for visual processing, estimates of at least 50%. If you look at the neurology, it's almost our entire brain is in some way involved in vision, involved with moving the eyes, involved with visual processing. And as a result of that, it's extremely common for vision to be impacted. One of the other things that you find is that because there's so much processing power that goes into vision, it tends to be one of the slowest systems to recover. And as a result, you have people who've worked through a variety of things that are very important to work on. Some of them might be life-threatening, some of them might be musculoskeletal. They're working on other areas, but vision kind of tends to linger. And so, as I mentioned, I think it's our responsibility as optometrists to do what we can in order to uncover what I had listed here as sort of the invisible deficit. So I had to list, there's no disclosures. This is all data from our clinic. Actually, it's interesting, we've been VT only for about 3 years, and I don't think we've had a rep in 3 years come by. So it's pretty crazy when you get rid of, I guess, drops and lenses. It's like you fall off the face of the earth. So, but long story short, this is all kind of data that's coming from our clinic. Now, there's a lot of amazing companies that work within vision therapy, but none of them are sponsoring the talk or anything. So I've sort of already alluded to this. I go to a lot of vision therapy continuing education, and I think that we do a really good job of communicating our why. You know, I think people know why we offer vision therapy. You know, it's to change lives, it's to better lives, it's to change the trajectory of someone's performance. I think the area that I'm hoping to work on today is to talk a little bit more about the what. You know, what is sort of the meat that drives what it is that we're doing? How do we know what needs to be done in terms of vision training? How do we know when we're finished in terms of doing vision training? And how do we measure our performance, and how do we measure things initially? So again, a lot of this is objectively driven, and I want to take everyone through the types of things that you can add to your exam in a matter of 3 minutes. That'll give you a ton of information about the status of someone's visual recovery. So a lot of this data, pretty much all of this data, is coming from a study that we have coming out in the next couple months in the Canadian Journal of Optometry, which is the effective vision therapy on measures of oculomotor function of patients presenting with post-concussion syndrome. So it'll either be coming out in June or September, but it's basically looking at the analytics of concussions and then the results that happen after someone has enrolled or worked through vision therapy. So again, if you want to kind of dive into the p-values and the t-scores and all of the statistics, of course all of that's going to be available. Today we're going to be talking about what the important general findings are. So when we talk about visual rehab or visual rehabilitation, I wanted to start by telling a little bit of a story, because I think that this will put us a little bit in terms of the framework of what it is that happens in general rehab, and an area where I would like to see improved performance in visual rehabilitation. So the story kind of begins, it was about 2 years ago, and I was playing a really intense game of Div 3 beer league softball. It was very intense. I was running between second and third base, and I ended up kind of going to slide into third, and I caught my ankle on the base, and it inverted entirely sideways. Just disgusting. It was sort of one of those 90-degree things, kind of just hanging off. I was limping to the dugout afterwards. And as a result of that, I got an understanding of what happens in terms of rehabilitation. The worst thing about the story was I wasn't safe. I was out too. So it was that added kind of insult to injury. But in terms of my process of rehabbing my ankle, the first thing that you generally do is immobilize. So we do that with vision too as well. You know, you're usually for the first week or two, you're limiting how much screen time you use, how much computer use that you do. You don't sit in a dark room. We know that now, because you need to move to get better. And the people who move within the first couple weeks are less likely to fall into post-concussion syndrome. But that being said, you still be smart about it. You know, you might limit classroom time, you might limit your workplace hours, the amount of time that you're going there, but you go through a little bit of a phase of immobilization. Same thing with my ankle there. The next thing that you work on is movement and flexibility, right? So generally what I might have been doing was some dorsiflexion and plantar flexion with my ankle, trying to rebuild that range of motion slowly. So how can we build that range of motion? I might do some light kind of balance things, some proprioception. I'm just trying to rebuild that range of motion. And a lot of that stuff is being done. There's a lot of people who understandably are incorporating vision in terms of their rehab program. It's out of necessity. You know, you can't do vestibular rehab without involving the eyes. A lot of chiropractors are doing kind of initial Vergence work, whether it's Brock string, whether it's heart chart, letter charts. They're working on these systems because you absolutely need to do that. You have to work on movement, you have to work on flexibility, you have to work on saccades, pursuits. You just have to get the eyes moving in that sort of initial phase. And a lot of allied professionals are doing this, and they're doing a great job of getting that, that initial sort of phase of recovery underway. As someone starts to get further into their state of concussion, maybe 2 or 3 months, one of the areas where I start to see we as optometrists play a really, really big role is in the third phase of the recovery. And this is an area right now that I'd really like to see change over the next 4 or 5 years. You know, with my baseball injury, you don't go back to playing sport right away. You have to work on proprioception, you're working on balance, you're working on movement under stress, you're mimicking sort of the gameplay. And what happens in vision is a lot of times people are moving straight into a return to play without being certain that they have the endurance, the stability, or the stress tolerance in order to handle what it is that's about to come their way. So how do we as optometrists measure endurance, stability, and stress tolerance? Because we're sort of unique in that we're one of the major professions that actually has that ability to measure those 3 metrics. It's really hard to measure, again, these sort of main categories if you don't have the types of tools that we have that sometimes we take for granted, whether it's a Vergence range or an accommodative facility. These tools can be extremely, extremely valuable in the post-concussion community. And in terms of the rehab, we have that ability to add this third phase of recovery. And I think this is where vision therapy really does shine and come into play. So as I've said, you know, in my experience, I think this is potentially the area that's missing in terms of a lot of people's recovery. It's that invisible deficit that I think we're, you know, as long as we are screening well and people they know to get their eyes checked and we know exactly what to test for, we can make sure that people find the right direction in terms of building this moving forward. So as I mentioned to you, you know, we see a lot of concussions, we see a lot of head injuries, as I mentioned, you know, 400 to 500 or so a year. And what we found is what I wanted to do was I wanted to get an idea of what I was seeing. I wanted to get statistics. I wanted to have an understanding of what it is in particular that you can expect to see in post-concussion cases. So what we did is we looked back on our results from back in about 2017, and we took a look at people who enrolled in vision therapy and where vision therapy was the main mechanism of treatment that we were going to go into, and we took a look at their statistics. We looked at all of the different findings and we sorted out what are the types of findings you can expect to see pre-injury. And when you find these sorts of findings, what can we expect after doing some form of vision training? So you can see here in terms of the demographics of the group we looked at within this study, again, we see a wide variety of people in general, but this was kind of the cohort we looked at in the study. The average age was about 42 years, so ranged from 12 to 62, so a pretty wide range. So what can we say about a 42-year-old in terms of the phase of life that they're in? Right? These are the, you know, they might be having, in terms of kind of their personal performance, these are the providers for their family, meaning that if they're not in a position to return back to work, or if they do return to work but have no gas in the tank at the end of the day, their families are suffering. It's really kind of heartbreaking within this particular age group. But again, we also have some complicating factors of accommodation changes, all of that sort of stuff. So teasing out whether this is presbyopia or post-concussion, we'll hopefully be able to go through some things that can help you do that. So time since injury, I'm very thankful that this has come down in the last couple of years, but in 2017, the average I was seeing people was 15 months post-injury, which that's just too long. It doesn't mean that you can't recover things. Fortunately, you know, I said the range is 2 to 30 months, but you know, in 2018 we were down to about 8 months as our average, and now this year we're closer to around 5 months post-injury, just through education and getting out there. And the sweet spot kind of for optometric vision therapy is we love to see people at around 3 months, like that, because that gives us sort of that next 6 months to guide, to direct, and it's easier to make these changes before we get these embedded deficits. Because vision, when it recovers, it tends to take the path of least resistance, meaning that people in bed with very inflexible Vergence ranges, very tight visual postures, and it's kind of hard to break them out of that when they're over a year post-injury. That being said, you absolutely can do it, but this is the numbers that we had, so that's what we'll be talking about today. Injury type, motor vehicle accidents were 38, we had sports-related 10, and falls were 8. And the delay in starting vision therapy, so they're 15 months post-injury, the delay is 6 weeks. So that's important about something we're going to talk about, which is how we prescribe glasses. So we term them, many of you have seen my reports talking about therapeutic glasses, and you're probably like, what is he talking about? So I'm gonna take us through what it is that we're trying to do with that. Essentially, a therapeutic pair of glasses is being designed to try and perform some sort of guiding action on the visual system. It might be yoked prism, it might be an adjustment to the lens power, it might be a tint, but it's trying to do some passive therapy on the visual system. So we generally like people to wear them for about 6 weeks or so, because we'll often find their symptoms do deflate quite a bit using the glasses, and then we can jump in and start doing some training and therapy. So what did we measure? So we measured quite a bit more than this, but what we ended up looking at was what ends up mattering in terms of visual performance. So first of all, what we found and what's been echoed in other studies, Goodrich had a study in 2013 showing, and what we found too is acuity is really a very poor predictor of the status of someone's visual recovery. It's very rarely impacted, and if it is, it's often a very subtly, and a lot of times has to do with an accommodative spasm or something along the lines where they're just not able to lock onto the target. So it doesn't end up being, we kind of know this, but it doesn't end up being all that positive in terms of an overall measure. Visual fields are a little tricky too, because again, earlier in recovery, these people are very light sensitive, they're very motion sensitive, and we put them, of course, in, these big bright orbs, and they've got to click and respond, and sometimes, the most common visual defect after post-concussion syndrome is scattered visual defect, and so kind of scattered, non-conforming visual field defects. So it's still important to do these sorts of things. A lot of times you might get better results just with a confrontation visual field initially, and then maybe kind of passing them on thereafter. So if those things kind of had a little bit less consistent findings, what actually did have consistent findings? What were the things that we saw that ended up mattering or meaning the most? So one of the first things we looked at was red-green near point of convergence. So we know with near point of convergence, we know generally you're tracking the object and reporting when you see double. What you want to add to this test, which I'm sure many people do, is having some subtle level of dissociation can be hugely valuable in terms of getting a more objective response. So we've got little slip-ins we'll put in people's glasses if they need near lenses, or you wear the red-green glasses and they'll track a pen light. And I've got a video to show you how you do it. I'm sure many people are familiar, but it does give you much more feedback and impact. The interesting thing is although NPC is receded, that's probably not the most important measure, and we'll kind of go into what may be even more important than looking at NPC. We looked at Vergence facility. So how many people test Vergence facility with the facility flippers? So by the end of this, everyone's hand is going to go up for sure, because this is the fastest test that you can add to your binocular vision exam, and it is so valuable in terms of determining where someone is in their recovery and whether they'd benefit from vision therapy. The test, if you do it in terms of cycles per minute, double it. It takes 30 seconds to do, and how the person responds to it is so powerful in terms of knowing how they're organizing their visual space. So Vergence facility is going to be important, and we'll go through that, of course. Positive fusional vergence and negative fusional vergence. Those aren't like sexy, exciting measures, right? But they're so valuable in terms of assessing the stability of someone's eye teaming. How we think of it, how much pressure can we put on your visual system before we break down binocularity? We've got our Morgan's norms table, which we reference in the study and we'll talk about. But the more you do these tests, you start to see that there's definite, repeatable, objective reductions in positive and negative fusional vergence at both distance and near, and I'll show you how much they generally expect to be reduced. Accommodative facility, as we know, it's a little age-related. You can't test it with everyone, but we still included it because we did have a handful of people, or more than half, that were within a range where you can test accommodative facility. I still think this is a really, really valuable test. And again, how someone responds to it is just as important as how many cycles per minute they end up doing. Depth perception. So I know I keep asking this, how many people measure depth perception regularly after someone's first appointment that they've seen you? Okay, there we go. So yeah, that's good. So one of the things is that, understandably, when someone first presents to our office, we'll measure stereopsis. And we usually measure stereopsis at near, because we know that, okay, the binocular columns are set, stereoscopic centers are firing, we're generally good. What you'll tend to find is stereopsis tends to be impacted following a head injury or following concussions. And a lot of it has to do with how that test works. You know, they might be dealing with an accommodative spasm or a Vergence spasm, and it's hard for them to fuse this slightly dissociated target. So we say what's one of the best screening tests for if someone needs to consider a binocular vision exam? Do you feel uncomfortable in a 3D movie? Well, we're trying to kind of mimic that a little bit with our testing. And if you have the ability to do distant stereopsis, it can be extremely, extremely important piece of the puzzle, and we'll talk about that as well. If you don't, that's okay. Near stereopsis is extremely helpful too. Eye tracking. So we measure eye tracking we've got an infrared eye tracker where we monitor people's eyes while they're reading. But the King-Devick saccadic test is quite well studied. It's quite well validated. It's a series of three tracking activities where someone reads the numbers out towards you, and you make sure they stay on task. You know, it generally doesn't take much longer than 2 minutes, and it gives you a really good idea on where their tracking performance is. Now, you don't necessarily have their pre-injury King-Devick findings, but you know what someone who is 15 years and above should be performing like. So you can reasonably assume that if someone is 40% slower than what a 15-year-old would be doing, that there's likely an impact in terms of saccadic tracking. And then symptoms. So there's a variety of different symptom surveys out there. We use the Convergence Insufficiency Symptom Survey. So for those who aren't familiar, it's 15 questions asking how people's eyes feel when they're reading, when they're doing near work. Do they get headaches? Do they get discomfort? Do they get tension? Do they get double vision? It's a really, really good sort of series of questions. And you'll see we've got it right on our website. You do take our screening test, and they'll answer the questions, and it tallies them for them. And if they score above 22, then it's likely that they have some sort of impacted binocular vision. So we included this in our study as well too. So this is something we use again, and we'll ask questions beyond that. So let's go into a little bit of the findings. You know, we talked about what it is that we're starting to look at, those cohort of tests. What do we actually see following in post-concussion syndrome? So the first thing we mentioned was red-green NPC. Not surprisingly, we do see a receded near point of convergence. But when you take the standard deviation into account, which was about 6, it's not always receded. You know, people generally can sometimes get the job done to closer than 10 centimeters. So you might want to watch how they're doing it. How their face, are they pushing back? Is there tension? Do they look like they're tearing? Is it extremely uncomfortable for them to do that particular activity? But again, generally you will see a receded near point of convergence, but not 20 centimeters. We were seeing, again, 13 centimeters as kind of being our average. On the right here, I have a little video here of how we test that. So we take a lot of video in our assessments. I'd say that I take video in 50% of my exams. So you can see here, she's wearing the red-green glasses. We're moving the light in. She's asking her to report when she sees double. So in that case, it was around 18 or 19 centimeters. After she reports double, you're pulling it back and getting a sense of where's the recovery point. When is someone able to recover? So you can see it's still double. She's still reporting double. It's still double. I think she got to about 55 centimeters or so before she was able to recover. So this is someone who, you know, they might be able to get that first 45 minutes of computer work done, but afterward they need 4 hours off. Their binocular stability is completely shot. So that's how we would generally measure near point of convergence. Next, what we'll do is we'll look at positive and negative fusional Vergence ranges. So these were the statistical findings that we saw in post-concussion syndrome. So when you compare it to Morgan's norms, you'll generally find PFVs and NFVs are at about 50% of what would be expected. So their stress tolerance, their endurance, their ability to hold that binocular posture while under tension and stress, that third phase of recovery we talked about with my ankle, this is where they're still struggling. And a lot of these people might be back at work, they might be back at school, they might be back on the field, they might be back to living their lives, but so many of them are reporting that they do what they need to do, but they have no gas left in the tank. And you can see here the stability of their eye teaming. And again, we're just testing eye teaming here. That's the only system involved. We're running on about 50% capacity. So not ideal in the near-centered world that we live in nowadays. The next test, I said that this is something that if you take anything away from today's talk, everyone should consider getting a 12 base out, 3 base in prism facility flipper. It's very, very easy to add to your eye exam. I've got some videos of how you do it. Essentially, you put a 12 base out in front of someone's eye and you ask them to fuse it, converge to make it single. Then you put a 3 base in and ask them to diverge and make it single. And you see how many cycles they should be able to do in a minute. People should be able to do about 15 cycles per minute, so about 7 in 30 seconds. What we found was this test was really, really illuminating for people who were struggling with functional visual deficits. So we were getting an average of about 2.4 cycles per minute. So these are people who are really running out of gas when they're in environments where they have to do a lot of convergence, divergence. So what things in life do we do that involve those sorts of things? Driving, walking into Costco, in a busy visual scene where there's a lot of different focal points. Their binocular system is running out of gas at 15%. Their gas tank is 15%. And they don't know what the issue is. A lot of these people will complain of, will cite dizziness as a big issue. They might call tension, they might call strain, but dizziness is really, really common in this particular group. And again, part of it is, if you start to have this unstable binocular system, your right and left eye are kind of telling you things are in slightly different locations. The world just doesn't seem stable like it was before. So I'll show you in these videos here of, again, what we're looking at. So on the left here, so again, what we're doing is we're looking at a target. I use a wolf wand. We're putting a 12 base out so he can clear the 3 base in easy. The 12 base out, you can't hear the video, but he says it stays double. It's just staying double. Isn't getting that Vergence response. You ask him, is there anything you can do to make it single? He really can't do it. And the more we started to do it, he started to get a little bit more uncomfortable. This is a laid back guy though. He didn't really kind of have the aversion type response that you'll generally see. You can see on the right here, when we took a look, this is kind of probably a more common response, is that when you're taking a look at, let's just see here. So when you add the Vergence facility flipper, you'll generally, a lot of times if someone's struggling with eye teaming, they have kind of a, pretty easy on the diverging. Head starts shaking, they start pulling away, they start reporting nausea. After I do this test, I often ask, where do you feel it? Is it in your eyes? Is it in your stomach? Is it in your head? A lot of people feel kind of nauseous, they feel unsettled, they just feel uncomfortable. So it's a test that, proceed with caution a little bit, because you might kind of put a bucket beside your exam chair. But no, it's usually 12 and 3 is usually not aggressive enough to throw someone into any major level of symptoms, but it's enough to kind of give you, okay, this person is really struggling. So the general population should be able to clear a 12 base out with relative ease. And again, within this community, these are people, they're 15 months post-injury. And they haven't been sitting in a dark room for 15 months. They've been doing a lot of great other rehab things, which we're fortunate in Kelowna. We have so many great professionals who are working on all of the other different aspects of concussion rehab, whether it's vestibular, whether it's cervical, whether it's auditory, whether it's nutritional. There's just a host of great professionals that encourage you to reach out to and network with. What we're seeing in this particular cohort was the challenge was, even throughout all of those things, we were having very, very fragile eye flexibility. That's what I think. That's what often I might communicate it is, your visual system has healed to some degree, but like my ankle, the flexibility, it's really tight. It would be like, if I had done some basic rehab on my ankle, and then the next level of rehab was to go run a half marathon before I had built up that endurance. So people, again, if they go into having to do heavy computer work, heavy driving, they just don't have the endurance to sustain what life asks of them. So pre-vision therapy here, accommodative facility. This was another really illuminating one too as well. People do not perform well with accommodative facility. So again, what is this? It's that flexibility of either the accommodative or the Vergence system. Again, we found that they're doing about 3.1 cycles per minute as an average. And so it's about 35% of what would be considered average. So, I use that term, like I said, flexibility and endurance as something where if you're seeing these types of things in the exam room, then vision therapy may make the most sense in order to get these people moving in the right direction. Because as I mentioned, there's so many great different ways of rehabbing yourself after a concussion. Vision rehab is very precise, and it requires use of filters, prisms, lenses, all of these different technologies in order to get the most embedded response possible, especially if it's been a while since the injury. So again, you can't test it on everyone, but as we mentioned to you, this is an area that we'll typically find we might see some challenges. So depth perception. I asked everyone about checking depth perception. This is really, really illuminating, I found. So in terms of our depth perception, so let's talk about distance stereopsis. The average distance stereopsis is still at 40 to 50 seconds of arc. What we're finding in the post-concussion population is they're having an average of 134 seconds of arc. So about a 60% reduction in their depth perception. So one of the interesting statistics that you find with concussions is once you've had one concussion, you're somewhere between 2 to 3 times more likely to have a second concussion. It would stand to reason that if your depth perception for gauging where things are in space is 60% reduced, the odds of you seeing that car coming, the odds of you seeing that player coming from the side, the odds of you kind of just maybe slipping or not seeing where something was goes up. And so it's really interesting to see that, again, the people who get these second concussions very commonly are not dealing with a full measures of stereopsis or depth perception. Like I said, 60% reduction. And near stereopsis is impacted too as well. And a lot of times that could be that stability of that eye teaming. We're finding that they're 50% of what would be considered average. So that stability is low. Sometimes you can find with lenses, you can bring that up quickly if you use even just a little bit of plus lenses or a little bit of prism, just a little bit of support. You might want, if you're testing near lenses, you might want to test it with your stereo book. Sometimes you'll see, you put a lens in front of someone and you might see, a 2 times improvement in their near stereopsis. It's not that you've all of a sudden, you've changed the binocular columns. It's that they can now perform that test more comfortably and more accurately. So again, depth perception reduced there for sure. Eye tracking. So I talked about this King-Devick tracking test. So generally someone who's over 15 should perform the test in about 50 seconds, reading those three sets of numbers in about 50 seconds. And what we were finding in the post-concussion group was they were taking 77 seconds on average. So it is, you might look at that and say, well, it's only 23, 24 seconds. But that's still a 35% reduction in terms of accuracy of saccades, and built up over 2 or 3 hours, that's yielding significantly reduced performance. So they use this on the sidelines in sports a lot of times, just to get a sense of whether someone's able to return to play. Some type of eye tracking, and if we can get access to the King-Devick, it can be a really, really helpful tool to add to your exam room. But again, we also will look subjectively at saccades. Watch the person, looking left to right, get some feedback on how they're feeling. There's a great screening test that's done in occupational therapy and physiotherapy called the VOMS test, so the vestibulo-oculomotor screening test. Take a look at some of that video on YouTube, and it's getting people to do saccades and oculomotor movements and vestibular movements and asking them about dizziness, asking them about nausea, discomfort, and rating it on a scale of 1 to 10. So we didn't include that in our study because we were focusing primarily just on vision or static vision, but you definitely can take a look on YouTube and learn how to do VOMS and start adding it and just learning more about how someone's performing. So symptoms, I mentioned to you that we do the Convergence Insufficiency Symptom Survey. You can see here we've got it right on our website. Take our screening test. If you're wondering, hey, one of the great things about this community is I know there's a lot of people who kind of will do a lot of great passive referrals where maybe just check out this site. This is from chiros, physios, optoms, what have you. We've added this so that people can go through the questionnaire. It'll tally up their scores and it'll tell them, okay, you're within normal limits or you're outside of what would generally be considered expected. But we were finding that people were getting about 39 points, so it's 39 out of 60, with the average being at around 22. So these people are walking around with with binocular eye teaming symptoms that are 56% greater than the general population. So again, it is a good test, and there's been some other studies, Alvarez and a handful of others who've used it in concussion assessments. And so again, having a scientifically validated study is really hard to do. Like these 15 questions, they're well constructed, and it was I think a 3-year, $2.5 million process to get these 15 questions together. It's not easy to have a great questionnaire that works in a variety of situations. So there's great other options out there. Feel free to add them. We do find that this does the trick for us. So in summary, who are we looking at? Who are the people that we were generally seeing? As we mentioned, an average of about 42.6 years old with a range of 12 to 62 years old. The time since injury, as we mentioned, that average was 15 months. We've been pulling that back slowly. As I said, our average now is at around 5 months, which is much better. We'd really like to be in that 3 to 4 month range to be adding some level of intervention, because it's just easier to modify rehab when someone's a little earlier in the process. We're not necessarily seeing people in that first week, second week, third week, fourth week. We're maybe a little bit further into the process. So, again, somewhere around that 2 to 4 month mark is a really great time to consider if these original findings were also found. Eye teaming, so we talked about that how their eyes are working as a team is about 50% of what would be considered average. That was the Vergence ranges, that was the Vergence flexibility. We have people operating with about 50% of what would be considered average. The eye flexibility, so again, accommodative, Vergence flexibility, this was a big one. They're operating at about 20% of what would be considered average. So again, these people walk into busy visual scenes. It's no wonder they feel they have to retreat within seconds of being there. They're basically kind of, like as I mentioned, the gas tank on their visual system is being drained almost immediately, instantaneously. So they avoid these situations, right? That's what you do. If my ankle wasn't rehabbed, I would avoid running. If your visual system's not rehabbed, then you avoid being in busy visual environments. It's just a natural defense mechanism that we all go through with all systems within our body. Depth perception, I said this was something that we found was really interesting. We're finding measures at about 40% of what would be considered average. For sure, that has to play into the fact that, as I mentioned, 2 to 3 times more likely to have a second concussion after you've already had your first. And it's a higher incident within that first 9 to 12 months of your very first concussion. So people have to, of course, be careful and be aware of that. And eye tracking, we said we were generally finding people are tracking at about 35% slower than what would be considered average. And symptoms, this is a big one. This is really what matters. These numbers, if all of these numbers are reduced and people are having a great time, they're not having problems, and they're back at work and they're functioning well, there are people who have convergence deficits that suppress one of the eyes, they're not dealing with symptoms, they're doing all that they need to do, life is fine, and those aren't the people we necessarily work with. You want to find, we kind of have a philosophy that I borrowed from another colleague that if it's not a problem, we're not going to make it a problem. If it's not a problem, it's not a problem. It's basically, but if someone's finding these sorts of very uncomfortable objective symptoms, then I would argue that it probably is a problem. So on average, as I said, and it's hard to average all of these things, but we found that their functional vision was at about 40% of what would be considered average. And again, these are people who've been going months struggling at work, maybe they're not even back to work. They're struggling with driving, maybe they're not even back to driving. Struggling having any energy at the end of the day for their family because there's so much demands that they have to deal with just to get through the day. So again, as I said, we're just looking at the visual functions. We're finding that when you look at static visual performance, we're at about 40% of what would be considered average. So, as I said, we're really grateful because I know within this room, I think we're very fortunate that we have a very good optometric community here. And what I mean by that is we get a lot of referrals from optometrists, and we're very, very proud of that fact. I would say, of the referrals we probably get 40% from optometrists, which is somewhat unique in the vision therapy world, is the honest truth. And we're really grateful for it. And I know people are doing these screenings and they're asking questions and they're sending a letter or they're sending a passive referral. So I really do appreciate it. And again, just to give you a little bit more hard evidence on, okay, when this is going to make a whole lot of sense, these are the types of things that you're going to find. So what do we do? What do we do to manage these sorts of things from a vision therapy sort of standpoint? So the first thing that I talked about was when someone initially comes in, almost without fail, we consider adjusting their glasses. Not always, but I would say in 90-95%, if someone's reaching a couple months post-injury, then we want to think about changing their lenses. And what we're doing when we're prescribing glasses therapeutically is we're focused a little bit more on our dorsal stream processing, so our motion processing. So we'll go through kind of just some examples of the types of things that I'm looking for, but we know that within the fibers of the optic nerve, 20% of them head semi-directly to our superior colliculus, and that's what's involved with directing movement. That's what's involved with gaze stabilization between head and eye movements. So we've got, and a lot of those fibers are coming from our peripheral or magnocellular stream. And so what we're trying to do is allow the visual system, for lack of a better phrase, to breathe a little bit more, to become more peripherally engaged and peripherally aware, so that someone can start to, because once you get that peripheral vision integrated a little more functionally, you can start working on the eye teaming more directly. So how many people have read The Ghost in My Brain? I'm asking bad questions, I'm not kidding. So this is a fascinating book. We probably get about, I would say, 50 people come to our office a year just because they read this book. And the reason is there's a large set of chapters within this book that talks about therapeutic lens prescribing and the experience of neuroscientist Clark Elliott. So he had worked with Dr. Zielinski. I'm not sure if anyone's familiar with her. She works in the Chicago area. She's been a wonderful mentor. I've seen countless hours of lectures with her, but she talks a lot about how to prescribe prism, yoked prism, how to prescribe tints, how to prescribe to integrate the auditory and the visual system. It's outside of the scope to go into all of the particular details. We'll go in generality, but suffice it to say that there's a lot of people, when you kind of help reorganize visual space, you can see some pretty profound changes in terms of performance. We've got 1.2 million ganglion cells that you can alter in 1 second by putting a lens on someone's eyes. And if you do that with art and finesse, and you can really start to see some profound changes. So the types of things that I'm doing with glasses would be different than what I would be doing if someone hadn't necessarily had a head injury. So as I mentioned, what are therapeutic glasses? What am I talking about when I reference that in an assessment? So when you look at a compensatory type correction, we know that what we're initially trying to do, it's focused on our ventral stream, our what is it pathway. So it's in a dark room, looking down the tunnel, max clarity, maximizing clarity, see the signs, see the ball, see things with precise clarity. And that's a really important way in which to measure glasses. We try and focus a little bit more on the dorsal stream. And so as you've seen, the vast majority of people who are involved in vision therapy, we move them out of progressive lenses, first of all, because again, even the greatest progressive lenses still do have peripheral visual distortion, which can impact the balance center, because again, it's coming down that magnocellular stream, which is feeding into that superior colliculus. So we're trying to let that visual system breathe a little bit more. A lot of times with cylinder, we know in a corrective lens, you do corrective cylinder, meaning that I've measured minus 0.75 at axis 73, and I might adjust it a little bit, but that's generally what I give, which there's absolutely nothing wrong with that. What you'll find with a lot of our lens prescriptions is they look a little simple, because what we might do is, because cylinder is again at an oblique axis and it still has magnification impacts, we'll often maybe orient it to 90 degrees or 180 degrees and cut it down. So 75 at 73 might become a quarter at 90, or it might be nothing really at all that we're going to be using throughout the course of therapy. Not always, but it's something that's a consideration. So just so people know, where the logic is behind that. In terms of prism, we know that generally with a compensatory lens, oftentimes prism is used to compensate. We more commonly in therapeutic lenses use yoked prisms. So one of the things, and I think that this is a good point to talk about it, I mentioned to you that people are generally, their visual system's often very inflexible following a concussion. And a lot of times these people are locked into, their sympathetic nervous system is on overdrive. They go into fight or flight very easily, kind of almost like the deer in a headlight. Their sympathetic nervous system, the autonomic dysregulation is very common. So I don't know if you've ever, had to shoot a free throw at the end of a sports game or something, a basketball game. And what happens is if it's a big game, you functionally close off that peripheral visual field and you don't have as many cues for depth. And what happens is if you're locked in that posture for an extended period of time, a lot of people following concussions start to demonstrate an esophoric posture at distance. That's very common to see people who are esophoric. Now, one of the things about prism that I think it's important to talk about is what we generally would do in a compensatory lens is we might give a base out prism to stabilize binocularity. But prism doesn't just move an image. Prism bends the world, it moves the world, and it also either compresses or expands the world. So base in expands the world, base out compresses the world. So I always just say, if I'm on my soapbox, I can kind of say, be very cautious about adding base out prism to these esophores, because what you're often doing is embedding this closed posture that becomes a lot harder to work out down the line. So you may want to, sometimes what we might do is give a little bit less minus to try and passively stimulate divergence. Because again, we know base out is a tricky prism to tricky prism to get away from. It kind of has those addictive properties, right? In the way that a myopic lens is too, right? But what we're doing again is it's compressing space. So just be cautious if you're going to use that. I'm not here to tell people what to do. Everyone here is great clinicians. I would just say maybe be a little cautious, because you'll see that an esophoric posture is really common. It's actually in the literature too that's not just my observations. That's something that is common. So in terms of tints, I know a lot of people have seen that we very commonly use tints in our glasses. And so a lot of times what we're doing is we might be using a certain tint that dampens critical flicker sensitivity, so kind of a lower wavelength like a blue or a green or something like that. Or we might use something that's enhancing motion processing. Remember with the Nike contacts, like a yellow type lens will enhance that. So we might be doing that subjectively, but we also take people through, you can see me doing it on the side, something that's called syntonic retinoscopy, which is we're using filters and we're observing retinoscopic response based on the tint that's being, and it's similar to if you put a plus lens or a minus, you kind of see the eye light up when there's a tint that's somewhat engaging. So there's a number of different tints that you can kind of trial and work through, and we found that this is very, very beneficial for guiding our therapy process, because you might see that they might be wearing a certain tint in their dress pair of glasses, but when they come to see us, they cycle through significantly more different tints while they're doing their eye tracking, and we're using retinoscopy a lot of times to guide that. So bit of a rabbit hole to go into kind of the tint theories, but feel free to reach out and I can direct you to resources to learn a ton more. So it's really fascinating actually, and it's been a hugely beneficial addition to our practice. And then as I mentioned, I still, 4 years in, I still don't have an autorefractor. I'm very focused on retinoscopy. I want to know what lens this person can tolerate. And the best way that I can generally do that is looking more at retinoscopic responses. It's not necessarily the lens that, again, as I mentioned, will get that best sort of ventral stream clarity, but it's the lens that visual system can tolerate. So I find retinoscopy to be the most valuable tool for that. So now on to the vision therapy. So again, as I mentioned, in terms of what's done in vision therapy, it's a bit of there's a wide variety of things that we go through, and I'm just going to touch on generally what we do, and then we'll kind of go into the results. But I think that the best way to kind of pass this along is just to tell, again, another little brief story. So about 10 years ago, I started to try and take up swimming. I tried to become a swimmer. Like, I've always had good endurance, like I've played sports and ran and done all these sorts of things. I tried to take up swimming, and I was absolutely atrocious. I think I got to red when I was a kid or something, whatever the color is that you won't die, but you're not going to thrive type thing. So that's what I had done. And so when I was trying to take up swimming, what I would find was, I would do about 2 laps and I was absolutely exhausted. I could run for 30 kilometers and swim for 100 meters and I was absolutely dead. My wife, on the other hand, can swim 40 laps and get out of the pool like she just did nothing, absolutely nothing. And so in terms of kind of working on my swimming skills or my swimming efficiency, you can't just jump in the pool and say, well, just keep swimming. Just keep swimming. The people who are struggling with reading, just keep reading. Just keep reading. The people who are struggling with computer performance, just keep working on the computer. Keep working on the computer. You sort of have to break vision down into its components in the same way you break swimming down. So again, what I would do is grab the flutter board, work on the lower body. Get the legs together, work on the upper body, focus on the path of entry, focus on breathing, focus on head orientation, focus on hip rotation, focus on what you do when you get to the end in order to bounce back. I'm still not a great swimmer, but I at this point, you can improve significantly when you focus on each of the different components that make up the particular task. And that's what we're doing in vision therapy. And this is where I really have to give a huge shout out to our team. I am convinced we've got one of the best teams in the world. It is unbelievable because, not only are they very, very capable vision therapists on our team, their ability to develop rapport is incredible. So people don't do rehab or training for people they don't connect with. That is just a fact of any type of rehab. And yet, the ability to connect with these people in a variety of different situations is so paramount to their performance. And I just have to, thank them for being amazing at taking people through these cycles. So the first kind of activity we might work on is something related to central peripheral integration. We've got a variety of different things, different activities. Feel free, of course, to come by the office. We're happy to show you some of the things we do. The next thing we might do is an eye teaming activity, so a Vergence activity. We might be doing a prism activity, like a training prism. We might have people we've got all the 3D training technology, the big TV screens, the fancy eye tracking gadgets. We've got all of that stuff in the office, and we might be taking them through some of that stuff that's related to Vergence or eye teaming. Then from there we might do an eye focusing, so an accommodation type activity, if it's age appropriate to do so. And then we would do an eye tracking, so something related to pursuit or a saccade. Again, we've got all the fancy lights that light up and you see it kind of go and you have to move your hand in response to it. And it's good, it's motivating. People, they can see their scores improving. You got variable lights, it's engaging, athletes love it, students love it. It generally is a lot of fun. And then we'll do something related in some capacity to motion processing. So by motion processing, it might be a Marsden ball moving where they're tracking letter. It might be that the client is moving and the target is stationary. So we have internal programs that we've worked on over the last 7 years or so, and you continually build and add more tools to what it is that you're doing. But we generally have a structure in terms of how we're managing these cases, and then we consult on them weekly in terms of what we're going to adjust or change. But generally what we find is in vision therapy, we'll often find that you're sequencing about 75 activities over the course of somewhere between 15 to 20 sessions. That's generally kind of how our structure is set up in terms of vision therapy. Now, one of the reasons we wanted to do this study was to figure out, generally for vision therapy, it's often quoted somewhere between 10 and 40 sessions is kind of the common length. And we wanted to kind of get a sense of what parts of vision take 10 sessions, what take 20, what takes maybe a little bit longer, and then from there, we can discuss it with insurance companies. We can discuss it with clients. Give them an idea of, okay, this is the reason why the length is what it is. So post-vision therapy. So we'll take a look. Again, as I mentioned, most of these people are working on average somewhere between 10 and 20 sessions. So near point of convergence, what we found, again, this is something that absolutely is modifiable. 15 months post-concussion, it doesn't matter, you can change it. And it's one of the fastest things to recover too. Gross near point of convergence, as I said, was in about that 10 session mark, we were starting to see that people were within what would be considered a normal range. It's important to point out though that their symptoms were not where they end up being if you work on the other areas of function. So it's so important to, again, as I said at the start, a non-receded near point of convergence is not necessarily does not necessarily mean that the person doesn't need to consider vision training or vision therapy. So their convergence ranges, as we saw here, in terms of their positive fusional and negative fusional vergence, we saw an average about a 2.5 times increase. And that was, again, the PFVs and the NFVs tend to take closer to around the 15 to 20 session marks. And you'll see in the study that we break it down, people who did 10 sessions, here's 15, here's 20. And we found that we'd get more consistent findings in closer to around that 20 sessions. The PFVs, or the converging and diverging at near, that stability, we saw an average of 2.7 times increase for converging and 2 times for diverging. These are, again, a little bit more closer to 20 sessions to get these types of findings. And as you can see, we'll compare it to, all of these are now well within meeting Morgan's norms. These are people who are now functioning. If they came off the street, I wouldn't be able to necessarily determine a functional visual deficit. And Vergence facility, I said, if there's anything people walk away from, hop online and find a Vergence facility flipper, really positive changes, 2.4 cycles per minute up to 13.1 cycles per minute. So that improvement's an 83% improvement in the flexibility of focus. So it helps with driving. We get a lot of people back to driving. It helps with busy visual scenes. We help people to be able to tolerate that type of environment really well. And a lot of that comes down to the fact that we're building that eye-teaming flexibility. And we found that when we break down the categories of how long they're with us, closer to 20 sessions was a little more consistent in terms of our results. Accommodation, again, we saw very profound and positive changes in terms of accommodative performance. We saw about a 71% improvement, so from 3.1 cycles per minute to around 10.6 cycles per minute. And we found that, again, we were at around that 15 session mark. It's not that we don't see a little bit more improvements with a longer treatment time. It's just a matter of, are they clinically significant improvements? Are they statistically significant? Those are the things that matter to us in terms of setting out these findings and setting out the results. And depth perception. So this is the one that we're really proud of. This for us is one of the reasons why we get a lot of, like I said, people back to driving, back to sports, back to feeling like, they're if they're a baseball player, they're hitting better. If they are, someone who's driving, they're more comfortable behind the wheel. We saw really profound changes in static depth perception. You can see at distance, we saw almost a 70% improvement in depth perception. And again, somewhere around that 15 sessions of training. Near depth perception or stereopsis, again, a 40% improvement, somewhere around that 15 sessions. So again, in terms of these measures of stereopsis, they're not necessarily static. And so, if there's another tool you can add to your post-concussion assessments, even if it's near stereopsis, that might give you some clues as to how they're dealing with maybe an accommodative struggle or a Vergence struggle. So again, we saw some really positive and powerful changes. And then with eye tracking, so again, we saw very, very solid and consistent improvements in eye tracking. Almost a 30% improvement. The average, as I said, for this test is around 50 to 51 seconds. So people are now tracking at age normals. So they're not having to work 30% harder to read that email or to read that document at work. They're much more efficient in terms of how they're using their visual system. And as I said, some of that, going back to the swimming analogy, some of that is we work on the saccades. The other thing is their peripheral vision is a little more engaged, so they know where to jump to next. And the other thing is their accommodative system is a little more accurate, so the words aren't going in and out of focus. The Vergence system is more stable, so the words aren't slightly doubling. And as a result, it's easier for them to predict where they need to move their eyes, and as a result, they do it faster. So that's what we generally, like I said, found with saccadic tracking. And symptoms. So really, this is the big thing, really. As I mentioned, it's really great to fix optometric data problems, but it's much better to fix the problems that people are dealing with in their life. And in this particular case, on average, as we said, we saw really profound and positive reduction in symptoms. As we saw, I said that average for that test was, above 22 is concerning. Our average, they were down 49% reduced symptoms, so scoring an average of about 20 on that particular test. So this is something that, again, this is someone who has more gas in the tank for work. They've got more energy towards the end of the day. They're able to get back to work so that they can provide for their family. As I said, this demographic is these people who are providing, and so I think it's, reducing their symptoms has a very, very big impact on their lives. And again, just to point out again, if you're wondering about the questions, you can take a look at our screening survey. Feel free to answer the questions yourself. And again, if there's someone who you're not sure, you saw a few things that were a little off, say, hey, because I know within an exam, if you've got 20 minutes or 30 minutes, you've got to look at so many things. I've got an hour and a half, and I'm looking at, this one sort of collection of things. So I sort of have time to really dive into this. I have time to trial lenses. I talked about therapeutic glasses. If I've got an hour and a half, we have people walking, we have people catching balls, we have people writing, we have certain kids cutting using different glasses. Like, we can really see how the lenses may be impacting motor performance or that output. And so again, if you're looking for a passive option, feel free to direct them to some of the questions that we have available there. So our summary, as I mentioned here, in terms of the visual system there, we found that before vision training, we found that we were seeing on average, and this was our cohort, their eye teaming was at about 50% of what would be considered average, again, compared to Morgan's norms. Post-vision therapy, they were operating at what would be considered normal, 100% sort of capacity. Eye flexibility, this was the big one, 20% of average, and following doing vision training, up to 87% of what would be considered average. And again, that time frame is on the right. These are around 20 sessions where we would find that. Depth perception, operating at about 40% of capacity, up to about 90% of capacity. Somewhere around 15 sessions or so, we started to see those findings. Eye tracking, 35% slower. Now what we're noticing is, again, they're tracking with age normality. And symptoms, as I said, we've got people who are 56% greater symptoms than average, and after, we've got people who are dealing with an average amount of visual discomfort or binocular discomfort. So in summary, as I mentioned, we said we're seeing these people who are at about 40% of what would be considered normal in terms of visual functional measures. And after going through vision training and vision therapy, we found that their visual function was closer to around 95% overall, which, again, I think it's important to underscore that, as I mentioned, we're seeing people later in the game. So it's not to say that vision therapy is the magic bullet that cures everything that someone is dealing with. We know a lot of work has been done before they make it into my exam chair. People are doing a lot of work to stabilize their vestibular system. They're doing a lot of work on their cervical system, auditory system, nutritional system, lifestyle. They're working with psychology. It really takes a village. When we looked at the specific visual findings, however, we found that this was the unique area that we're able to add to the rehabilitative community, which, again, there's a lot of different people who are offering a lot of fantastic services and programs. We wanted to figure out what we do that's unique, because if you better understand what you do that's unique, then you end up making sure that the right people are finding you. So in terms of our discussion, we found that the results of this analysis supported findings of previous studies and demonstrated statistically and clinically significant improvements of measured oculomotor functioning in patients presenting with oculomotor deficiencies associated with post-concussion syndrome, and support VT as a viable treatment option for these associated symptoms. Furthermore, as I mentioned, what we found was presented results suggest longer treatment times might improve measured outcomes comparable to patients receiving 10 vision therapy sessions or less. And that's why I wanted to tease out each category. There's some things that we did see we were able to get done in a shorter period of time, but again, maybe the legs are working well while they're swimming, but they don't have the proper arm movement, they don't have the right breathing pattern. It's not all coming together. And what we found was, within the paper there's 32 different references. We found that we had similar findings to, the Ken Kafrida papers, the Scheinman work, the work of Alvarez, a lot of other people who've done this type of work. Was, again, we're trying to add to that body of science and evidence that is out there for what it is that we do. So in terms of the in terms of that's sort of the science conclusions. These are the types of things that we hear all the time. And I don't mean to kind of just blow smoke and say everyone walks in and just loves everything, but it is a really positive, amazing environment when people make it into, it's kind of like a refuge for them sometimes. And in this lady's case, we've got hundreds of different collection of people who've had really positive impacts. And in her case, she had mentioned, again, her glasses, they feel like magic. I had a little kind of cheeky line there. A lot of people in our therapy room kind of term them their magic glasses, and it's kind of because they've put them on and it just kind of deflates some of the pressure and tension that they might have been dealing with for 6 to 9 months. And in this particular case, as I said, she mentioned the vision therapy. It's not that it's easy, but it really can have very profound impacts on someone's performance and life. So I'm kind of a take-home message person, so I wanted to talk a little bit about the types of things that I think are important to consider. So as I said here, optometrists, I feel, I want us to all feel empowered to know, I've been in the rehabilitation community for a long time now, and we have such unique skills to measure visual performance. And, we sometimes I think that, I don't want to say that they're underutilized, but we don't often know our value in terms of this binocular measurements. It can be so helpful for so many people within the rehab community for us to provide this objective data. And it's so hard to measure it if you don't have the types of tools that we as optometrists do. So I really feel that we're uniquely capable of screening for these issues. We're uniquely capable of monitoring process, and we're uniquely capable of guiding training and recovery. The interesting thing is, a comprehensive vision exam, as I've talked about, throughout this assessment, it's not yet part of the international consensus on concussion management. Which to me is shocking. But that being said, I think that the goal here is when people have visual issues, they know to come to their optometrist to get their eyes checked. And so even if they, aren't doing the full sort of comprehensive, we can add some things to their assessment that I think can get them moving in the right direction. So, I appreciate everyone in here for doing such, as I said, an amazing job and, being so supportive of the types of things that we're trying to do within the community. As optometrists, consider stereopsis, Vergence facility and ranges. So again, that's a quick 30-second test. Eye tracking, and then that symptom survey. If you consider adding those things to your exam, even if the symptom survey is something they fill out afterward, I think it can be really helpful in terms of at least getting people to think about how their vision might be impacted. One of the things that I say, to many of our great referral sources is, it's actually funny, when someone comes to us and they work with us, they might be with us for 5 or 6 months and they've really made some positive gains. Who do you think that they think most highly of at the end of the program? And I'm not just blowing smoke, it's the person that sent them in. They're always coming in and they're so grateful for the fact that someone identified that this was an issue that they could work on. And so again, it's very, very common that people will express that. So again, giving them tools to sort that out or to determine what might be an issue, I think can be very valuable for your patient base. So, and when they're finished with their program, of course, we're not a primary care optometric clinic. If a child's doing vision therapy and the parents would like to get their eyes checked, we don't offer that within our center. Around 15 to 20 sessions of vision therapy is generally sort of considered ideal. You can be more in complex cases, for sure. So this was, again, a set cohort of what we're looking at. When you go with longer treatment times, there can be other factors in play that kind of muddy the waters of what you're doing in terms of science. So we wanted to focus on people, as I mentioned, who were primarily just doing vision therapy. And again, we found that this was a good length of time for working with these post-concussion cases. And as I said, it takes a village. It takes the people who are assessing for functional visual deficits. It takes all of the hard work that's being done by other professionals before they get in to see us. we can't work on the visual system effectively if someone has BPPV or something like that and dealing with vertigo, or if they have, major cervical impingements. It makes what we're doing significantly more challenging because, again, all the neurology of the eye movements is originating around the midbrain. So again, back of the head. And not surprisingly, people who get whiplash or hit the back of their head with a concussion will often have more visual deficits than someone who hits any other part of their head. So again, as I said, it really does take a village in terms of managing these particular cases. In summary, kind of at the top there, I talked about baseball. I talked about my experience, and I'm back to playing baseball. But I'm not getting drafted anytime soon. It doesn't really matter all that much. It matters to my lifestyle, but it's not really that big of a necessity in my life. Computer work, driving, the ability to earn a living, the ability to go back to school, all of these things, these do matter to people. And so, as I mentioned, that third phase of recovery, that stress tolerance, that flexibility, that endurance, that's really where we as optometrists can help guide and help train. And I hope that from today, you have a few more tools and just some data to look back on and reference to know if someone falls into fitting the category of needing to consider vision therapy.